Morning, everybody. If I could have your attention and tear you from your coffees for a second. My name is Niamh King. Good morning. I'm the Vice President for Programs here at the Chicago Council. Today's program is on the record. You can use your social media, and it's being live streamed, but please do silence your phones so we don't interrupt it. And we're delighted to welcome you to this very important conversation that we're having as part of our Women in Global Development Forum series. As many of you already know, we founded this series in 2009, and we're thrilled that 6 years later, nearly 7 now, it's going strong. And today's conversation was originally due to be part of our Global Health Symposium that we host around International Women's Day. The weather was not cooperating last year, some of you may remember, but thankfully our speakers all agreed to come back, so we're delighted that they're here. Thanks very much to AmeriCares for their continued involvement in this panel and their patience in bringing it to fruition. As many of you know, council programs are member supported. That's why you're here. It's why we can have loads of students, particularly at this important series. So thank you if you'd like to join. It starts at $100. We have a special right now, a holiday special. I think it ends tomorrow. So check it out. And I'd encourage you to get one for yourself and several for your family members and loved ones in this holiday season. We have some great sponsors for this. Abbott Laboratories, USG, AbbVie, Citadel, the Frankel Family Foundation, Kirkland & Ellis, Ashley F.T. McCall and Avery McCall, Skidmore, Owens & Merrill. Thank you very much for your support. A few upcoming programs. Our next conversation, as you know, what's going on in Paris right now, the COP21 talks. We're hosting a very special person, actually, a woman who works with indigenous peoples in Indonesia. Her name is Mama Aletta Baun. She'll be talking about climate change and its impact on indigenous peoples. After the break, January 27th, we're doing a partnership with the Goodman Theatre. As you can see, we've been doing this with lots of places around town. We did lyric opera last night. We're going to be talking about women in prison. It's part of a discussion we'll have before Another Word for Beauty. And then, as we're talking about the Global Health Symposium, save the date, March 4th, a great day to march forth and do good things in the world. We'll be hosting our Global Health Symposium. John already has some fantastic people lined up. We're very excited about it. We'll be talking a lot about the next generation, so we hope you can join us. And now, if you'll please join me in welcoming to the stage Holly Copeland, who's the Associate Director of Public Affairs and Corporate Social Responsibility at Horizon Pharma. She'll introduce our panel. And Holly also just became the newest corporate member, Horizon did, at the Chicago Council. So thanks for your support, Holly, and welcome to the stage to our group. Thanks.
Thank you. So good morning. I hope you all are enjoying your breakfast. My name is Holly Copeland, and I represent Horizon Pharma and head up their public affairs and corporate social responsibility. Engaging more women in the field of health science is a priority for Horizon Pharma as we seek to foster their interest in healthcare and to provide them with opportunities to enter, grow, and advance in the field. And I am delighted to see so many of you here this morning to engage in this important conversation. Our mission at Horizon is to help patients live better lives by developing innovative medicines that drive better health outcomes and address the unmet needs of patients. As a leader in health sciences, we believe we have a responsibility to identify ways to support and strengthen resources for individuals working worldwide to provide care and improve the health of people in their communities. Careers in healthcare offer women the opportunity to explore and engage in some of the most meaningful areas of research and development, technological innovation, and patient care, which not only enhance individual health but also global health. Around the globe, women are often the first responders to catastrophe. From outbreaks of disease to natural disasters, they are on the front lines of crisis, response, and recovery work in their communities. And yet, in many countries, they face a range of challenges in these efforts. This includes poor training, lack of payment, and inadequate access to essential supplies such as clean water and infection-free blood. Because of their unique and central role in this work, women are disproportionately impacted by these challenges. This reality was brought home by the 2014 Ebola epidemic, where women accounted for 80% of Ebola-related deaths in Liberia alone. How do we better respond to the needs of these brave women as they provide care during the most dangerous health crises and natural catastrophes around the globe? This morning, we are delighted to welcome an expert panel to discuss these challenges. I look forward to hearing their thoughts on how to better protect women by creating more responsive urban and rural infrastructure and providing the necessary resources. You have their bios on your chair, but let me briefly highlight a few points. Our first panelist is Eliakim Tomidi Archer. She is the Senior Director of International Partnerships and Programs at AmeriCares, where she has led the launch of many programs, including the Health Worker Safety Initiative in Tanzania. Archer has extensive experience in public policy and strategic management consulting through her work with the Civic Consulting Alliance and Search for Common Ground. Susan M. Blaustein is the Executive Director of Women's Strong International, a consortium of nonprofits working with impoverished women and girls in cities around the world. Prior to this, she led the Millennium Cities Initiative, a project of the Earth Institute designed to help sub-Saharan African cities achieve the UN Millennium Development Goals. We are also pleased to have Veronica Arroyev with us this morning as moderator. She is the AbbVie Foundation Director of Corporate Social Responsibility. Her experience spans the private, nonprofit, and academic fields, including positions at MAP International and the Partnership for Quality Medical Donations. After the panel discussion, Neve King will return to the stage to moderate audience question and answer. Ladies and gentlemen, please join me in welcoming Eliakim Tomedy Archer, Susan M. Blaustein, and Veronica Arroyev to the Chicago Council on Global Affairs.
Good morning, everyone. Thank you so much for being here. It's nice to see a good crowd come out for us today. As we begin to explore the fact that women are at higher risk during public health crises, one of the things that we're going to explore today is looking at Ebola, which served as an example for us to study and for us to reflect back on as we discuss today with Eliakim and Susan. We're very excited to have them here. So one of the things that the Ebola crisis highlighted were the gaps in healthcare and the gaps in the health system, strengthening opportunities that evolved from that. And one of the things today as we explore is, Eliakim, perhaps we could start with you and say, could you first give us a brief explanation of your work at AmeriCares? Paint for us a picture of what happened during Ebola in terms of the Ebola crisis and how you responded, and then how that crisis impacted women.
Thank you, Veronica. Thank you, everybody. Good morning. It's a real pleasure to be here, and I'm glad we made it despite the snow the second time around. So AmeriCares is an emergency response and global health organization. We are committed to saving lives and creating healthier futures for people here in the US and across the globe. My role there, I lead our global health portfolio. I oversee our work in Middle East, Africa, Asia, and Eurasia. And in this role, that means that during the Ebola crisis, my team was focused on supporting our emergency response team in working in all three countries, in Guinea, Liberia, and Sierra Leone. And then as the crisis ebbed and moved into the recovery phase, our team now took the lead in really working with our local partners, the ministries of health, the district health officials, to build a better and more resilient health system. How did the crisis impact women? I think when we think about the Ebola crisis, we see it affecting women probably, I would say, in 3 or 4 principal ways. The first we saw was as health workers. So in a lot of these countries, the women are higher nurses, midwives are likely to be women, the nurses are likely to be women. So we saw the crisis affecting them as health workers. The second way we saw it affecting women is as care providers. So at home, they were taking care of their sick babies, they were taking care of their family members, of their partners, their spouses who were sick. And then as patients, the third is as patients themselves, they were seeking care. I think I recently saw a statistics that said in the period of the crisis, the rate of pregnant women seeking health services in Liberia alone dropped by 19%. Now, this is a country that in the rural areas, less than half of the women are seeking care for maternal health services in health centers. So if you have a drop of 19% in that really small group already, that's a staggering number that we are talking about. Then the last way that I think we saw the crisis affect women is not necessarily health related, but it's affected them as single heads of households. So again, in the Mano River Basin belt, which is where we are talking about Guinea, Liberia, and Sierra Leone, you know that in the 1990s, they had a long history of civil war. And so a lot of men were lost. And so there are a lot of women heads of households in those communities. So during the crisis, we saw that the roads were shut, whole communities were cordoned off, they could not really earn a living. And so we started to see then, because they were losing their source of livelihoods, this also affecting them. So when you think about it, I think you have to think about health workers, caregivers, patients themselves seeking care, and then also as heads of households trying to take care of their family economically during the crisis.
Thank you, thank you. Well, Susan, would you give our audience a better sense of the work that you do and how you understand the Ebola crisis and how it affected maybe the fragility of the health system?
And thank you so much, and good morning, everyone. I think Holly and Elikem have both kind of painted the picture, both in the large and in the kind of very specific detail of how Ebola has...
Please use the mic.
I'm sorry, how Ebola has disproportionately affected the women. I think we've had a good introduction to that. And I would just say in terms of the health system that over 10 years of working across sub-Saharan cities as part of the Millennium Cities Initiative, we carried out the UN Millennium Development Goal public health needs assessments, many other needs assessments as well that are related, like water and sanitation, gender, education, et cetera. But the public health needs assessments in 7 cities. And now with Women Strong International, we're working not only in the sub-Saharan region, but also in southern India, northern Haiti, and southeast Washington, D.C. And I would say we've just seen gap after gap after gap. And you know about these, we know about them even, in Chicago and many American cities of Native American communities, et cetera. More like lethal gashes, actually, in the healthcare system, which we then, as part of my projects, have tried to identify, to bring to the attention of public officials, and to fill these gaps, either by bringing in a capable partner, such as AmeriCares, which we've done on many occasions, or by ourselves, if it came to designing a program and then bringing in experts to teach it. Just 3 examples of these lethal gaps. Across the sub-Saharan region, outside the national capitals, with a couple of notable exceptions, there's really no safe blood. So a patient comes in hemorrhaging from postpartum, from Ebola, from a vehicular accident, which is the 2nd largest killer, I think, still in sub-Saharan Africa. And there's really no hope for that person. They are asked to bring their own blood. We had a little girl brought in, we were doing a fistula repair project. A little girl came in a car accident, and she had to go to her uncle, this was in Mali, to bring blood. Well, who's her uncle, and what kind of blood, So it's a disaster, and it's a disaster for the public health workers as well, of course. A second example would be the frontline health workers who are not really properly trained as emergency caregivers. They're trained in community health, nutrition, if they're good, identifying who's malnourished, who's disabled, who's pregnant, so that you can keep an eye on those people. But they're not trained in emergency, so this puts them at great risk as well as their populations. And then finally, if a person is lucky enough to get to the facility and to be admitted to that facility, which are overwhelmed and have very poor triage systems, there are almost always insufficient consumables, as Elikem well knows, equipment, and staff, meaning that the provisions of such simple things as IVs is not a simple thing in this context, but antibiotics, analgesics, gloves, even just clean water are often not available. So I saw a row in a hospital, not in any of the wards, this was in Western Kenya, lined with people on stretchers on IVs for cerebral malaria, so there's no room in the wards. There's no water in this hospital. This is a hospital. And the ambulance, PS, was up on boards. And you say to them, well, how long has this been up on boards? Meaning no wheels, the ambulance, and they say, oh, about a decade, So who's going to reach the sick people? It's just a disaster. And from the point of view of the citizenry, as the Ebola crisis proved, women and girls are, as Elikem put in detail, at far higher risk, not only during an epidemic, when, of course, there's likely to be significant displacement of population. So the girls are kind of lost, the women are vulnerable, et cetera, but also after the epidemic. And as we learned from Ebola, when the men recover, they're eager for sex, which is a natural thing, but they're sperm still carry the virus for a protracted period. And who would know that? I mean, we learned that in the course of the epidemic. So these are the kinds of things we have to learn. And having had our blizzard and being able to convene 8 months later gives us a different perspective, because we can look at the system as a whole and see what gaps really need to be filled all along the way to prepare for such an epidemic and just to handle your daily kinds of emergencies, such as we saw on the West Coast yesterday. Thank you.
Thank you. Thank you. Insightful. Thank you very much. So we know that the entry point for health systems are hospitals and clinics. And as we find individuals who are at risk, and most risk, frontline workers tend to be at these facilities, health caregivers and patients that have higher rates of being able to contract the Ebola. One of the things that we want to discuss today is, Elikam, if we could start with you, could you tell us more about what those risks are, and then some of the steps that maybe AmeriCares took to mitigate those risks and to bring solutions?
So I think Susan talked a lot about the health system, and I think it is important, even before we go into Ebola, to have a better view, a better view of what the health systems we're talking about pre-Ebola. So you've got to understand how it was like before Ebola, and then you can understand how the onset of Ebola really heightens the risk to people. Two examples that come to mind: in Tanzania in 2008, when we were doing an assessment for our health worker safety initiative, and this is in a 900-bed hospital that gives a lot of care. The catchment population is about 13 million, since hundreds of thousands of patients. In talking to the health workers there, they mentioned that in that hospital they ran out of gloves. Example number one, I'll come back to that. Fast forward a few years later, I think in 2012, we were in Liberia doing a similar assessment, and also we're talking to health workers, nurses, and doctors again in Monrovia, one of their big hospitals in Monrovia, and they told us that in the hospital, when you walk in as a nurse or a health worker, you get 4 pairs of gloves for the day. Doesn't matter if you're seeing 20 people, 10 people, 40 people, you get 4 pairs of gloves because that's what they have. So when I think about those two examples, this is before Ebola happened. Health, and then I sort of always say I want to compare it to my life here in the US, in my kitchen and in my home, how many gloves I use, like cleaning the bathroom, washing dishes and things like that. And you imagine when you go to your doctor's office here, they take your temperature, they change the gloves, the nurse comes in, they wear another set of gloves. For me, I think because I straddle both continents, it's always amazing to me. I sort of watch what happens but this is the system that existed before Ebola happened. And so it is the lack of consumables, there's the lack of basic protective equipment, all those things existed. And then we have in it an outbreak of a highly contagious infectious disease. So that is a recipe for catastrophe, as you can imagine. And so, as you know, during the crisis, the health workers, I think the thing that shocked the world the most was the fact that so many health workers were lost. But why would they not be lost? They don't have gloves to protect themselves. They don't have basic masks. When people think about Ebola, they think about the suits with the goggles and all that. That's for the high risk, like in the treatment unit. But for a pregnant woman walking into the village health center, the health worker really just needs a pair of gloves and maybe a mask until they can determine what is going on. And that basic supply does not exist. That's the weakness of the health system that existed before Ebola. So the ability or the risk in transmitting infection from patients to health worker, from health worker to another health worker, is just really high before Ebola. So that was the backdrop, and then Ebola happened, and so what did we do? So one of I think three things. First, protecting health workers. So AmeriCares has been working on health worker safety before it became a public health, global health priority for anybody. And so we've really focused on what we've always argued was important: protecting the health workers, sending in millions of protective equipment because Americas works as both an emergency response and global health organization, and we have partners in over 40 countries. We were already on the ground in Liberia and Sierra Leone with our partners, so we actually started to respond to Ebola in April of 2014, before the international community really started looking at it in August and September of the year. So protecting the health workers by sending in the protective equipment, but also doing the training on infection prevention and control. Susan knows, and a lot of you who have visited hospitals in developing countries, there are no protocols in place for infection prevention, cleaning, waste segregation, things like that, that again are part of the business here, do not exist. So training on infection prevention and control. And one of the things that I do want to highlight that is important, it's not just during Ebola, there were a lot of people doing training on IPC, infection prevention and control. But what we have found is pulling people out for 1 week or 1 day or 3 days to do the training really doesn't change behavior. What you need is the systemic monitoring, on-the-job training, supervisory monitoring that really changes the culture of the facilities that you're working in. So the other thing that we did is just enhancing the treatment capacity. So we know that USAID, the US government and the Department of Defense built all these Ebola treatment units, and they needed NGOs to step up to staff it and really provide treatment. So we did, in partnership with IOM, the International Organization for Migration, staff up one of the treatment units in Liberia. And then the other thing that we also focused on, as we started to move from the crisis phase to the recovery, and now we are more in the building back, hopefully better, we really shifted attention to working with our local partners, ministries of health, to build a better health system. I really think that it's really about the comprehensive health system, and with a focus on safe motherhood. I'll come back to that later, but it is not just one solution. Really, the whole health system was broken before Ebola, is currently broken, was broken during Ebola, and we do need to build the whole system back better.
Thank you. Thank you. So Susan, I know that your focus, a lot of the work that you've been doing is focusing on integrating solutions. If you could tell us, when you consider the challenges that the health workers faced, what are the key factors in place that you know, in terms of the work that you do, that support those efforts?
Well, thank you. And I would just say that AmeriCare's emergency responses should be like a model, because they don't just come in, you know, with what they think is needed. They are there. They're already there, so they know it's like some of the rescue work in humanitarian disasters. This is exactly that, and they should be emulated and praised for that. From intake to exam to treatment to recovery to release, it's a disaster, as the Ebola epidemic proved. And there may be many, and there are, well-trained, highly capable people, but there are also undertrained people who have the one-day training but not the hands-on follow-up training, miserably equipped and highly vulnerable. In terms of integrated solutions, one very successful and an interesting thing put into place in Kumasi, Ghana, by the Director of Health for the whole Ashanti region, himself an OBGYN, was the system of accountability. The emergency here, pre-Ebola, again, was maternal and neonatal mortality, which was just rife across the region. And you know, as an OBGYN, he was horrified by it. Women in complicated labor would just be passed along from home to clinic to metro level to tertiary care center, where they would, as I said, the triage system is so weak that they would languish on the porch of the facility and often die there right on the terrace before even being admitted. The newborns, I saw this, were crammed 5 to an incubator in the neonatal ICU. So the situation was appalling, and a terrible lesson, of course, for a teaching hospital, which in fact this was. So Dr. Yeboah Awudzi told every medical practitioner in his region that they were responsible for the fate of each patient they treated. to see that that mother wouldn't die on the porch of the hospital, to make sure that the blood was properly sourced and administered, that their own primary and secondary facilities had people trained in neonatal resuscitation, which has saved countless lives at that golden minute just after birth, when the baby can seem dead, stillborn, but in fact is just asphyxiated. And if you know what to do, and I've been trained in this, I wouldn't trust myself, but it's not rocket science to save a baby's life, but you need to know, And then finally, the reporting and the patient tracking, which of course is sort of aspirational in a place that has very poor internet or communications. And look, I mean, even with good connectivity, we've had challenges here, right, with our own electronic medical records. But with the patient tracking, you're much better able to create and ensure an integrated system of care. So this is one way, an initial step that's relatively low cost to get at, in particular, in underserved settings, those afflicted by all kinds of things, is to be able to feel implicated in that patient's outcomes.
Thank you. So now that we've covered one side of the risk of frontline exposure, there's another element, and that's caregivers at home. Perhaps, Susan, we could start with you, and you could walk us through the risk factors that are facing families. And the second is maybe what education, training, and services can be provided.
Thank you. Well, the risks are, of course, enormous. I mean, from hygiene education to proper hygiene. The water provision is scanty at best. Sanitation is often non-existent. We found in the streets of Ghana's capital leaks in the middle of the dirt path that have cholera in the water, and we've reported this. We've tested it time again, and nothing happens as a result of that. Gathering places, markets, schools, churches, mosques, clinics are, of course, where people are most at risk, but they're also the places where they're most likely to get useful information. So this is a difficult paradox to manage. Tools that can be effectively implemented are community radio, as we've used in Kumasi to spread vital health information, and also opportunities. Come be screened for hypertension on Thursday afternoon. The radio can go out across the market or from the mosque. SMS or texting, as well as WhatsApp and some other applications that are being used in some of our settings. Home caregivers, teachers, religious leaders, public market leaders need to be trained in the most essential information regarding personal hygiene and care, family health and nutrition, what to do if someone's exhibiting symptoms, how to be tuned into the needs of the most vulnerable populations, the disabled, for instance, and the elderly, pregnant women, adolescent girls, those in outlier tribes and communities. And they need to communicate these things, as Elikim said, not just once in a forum where everybody's kind of glazing over because it's 7:30 in the morning, but over and over again. We're using skits, radio programs, classroom exercises, songs, mnemonics, billboards, posters, texting, et cetera. Kind of any means that's available. All these can be mustered as tools for getting out messages about how to be safe. And finally, what we've done in non-crisis settings that seems to work, and it's kind of an interesting community organizing tool, is to put together what we in Washington would call an interagency task force. But in these settings, such a task force or community council would be comprised of a public official, imam or pastor, women religious leaders, head teacher, principal, respected business leader or two, farmer, trader, whatever the work is, adolescent girl, boy, and a public health nurse or community health worker who can make everyone aware of some of these issues. Again, the critical importance of simple hygiene education, which we found in our project in northern Haiti. The cholera epidemic just went rife even at the source of the river of the problem, which was hundreds of miles away from the earthquake at that time. Whom to touch or not, what to look for, how to be on the alert for sick or possibly ill people both within and beyond your community, whom to call, where to go in the event of emergency, all these kinds of things which seem kind of native to us. I mean, we have a little list of phone numbers on my wall, ever since my daughter was born, of she's in college now, but whom to call in the event of an emergency. But people are just so busy going about their lives that they don't take time to think about these things. And as any of you who've been trained in EMS, know, you have to have it has to be second nature so that you can pull it out the drop of a hat, like we saw done so brilliantly yesterday in the tragedy in San Bernardino. So, and of course, the extra risk to adolescent girls and women. So I'll stop.
I didn't make a face. So, Elika, maybe you could give us your perspective on caregivers at home, and give us some insight in terms of the work that you've seen with AmeriCares.
So, so like Susan said, I do think that if you're talking about health and solutions, incorporating the caregivers at home is an important component of it. And I think we didn't do as well as the international community responding to Ebola with the caregivers at home. We've really focused. It was a crisis situation, right? Everybody was running. Doctors were dying. Lead doctors in the country were dying. You were focused on that. We were so focused on the treatment units, staffing them up. And we all saw the pictures of the communities cordoned off and soldiers and a very militarized response rather than an engaged public health approach, leveraging the community workers as agents and part of the solution rather than as the victims and the problems. So I do think that integrating the community and supporting the caregivers is really important. One of the things I feel like, again, now 9 months later, we can look back and sort of talk about is we didn't leverage, and we should be leveraging the community health workers. We saw a complete breakdown of trust between the community and the health officials and the health workers. They are community health workers that are from the village. They live there. They know the people by name. They know their family members. We could have actually really leveraged the community health workers to bridge that gap between the messaging that sounded really foreign. Take your sick baby to the treatment unit and they may not come back and you can't bury them and why and I won't see them anymore. But community health workers who are part of the community, trusted voices in the community, we could actually have used them really well to build community trust and let the community be part of the solution. I also think that one thing that was a missed opportunity is the Ebola rapid test kits. They were not available during the crisis. Can you imagine the difference it would have made for a health worker and the patient to be able to tell within a matter of an hour or minutes whether the child with diarrhea actually has Ebola or just has plain diarrhea and needs some ORS and love and go home? But we couldn't tell because we didn't have the rapid test kits. And so this was something that, again, made the connection to the community really difficult. And we could have given those rapid test kits to community health workers in the community. So when there was a sick baby or a sick mother in the family who was pregnant, you could determine quickly what was going on and decide what the triaging process needed to be. So I really do think as we think about health workers, it is important to integrate the community members and the caregivers and give them tools to be part of the solution rather than as victims or people to be excluded from the process.
Thank you. Thank you. So health is only one aspect of providing for healthcare workers and providers. You know, what's extremely important is building stronger, more resilient communities. And as we all know, investing in women is a major component of building a strong community. Perhaps we could start with you, Susan, and you can tell us a little bit more about the communities that you've worked with, especially in the work that you've done with the Millennium Cities Initiative. And then maybe you could talk to us a little bit more about the communal approach for education, training, and public health in the work that you've done.
Thank you. Veronica, wherever we've worked, we've observed that the most effective work being done on the ground was done by women who know very well what they and their families need, but who often lack the skills and the resources, whether technical, financial, or political, to fill these needs. With the Millennium Cities Initiative, we had to persuade government officials to listen and to do what the residents of each city felt was most needed in order to achieve the Millennium Development Goals. And except for a few hard-won victories, this proved less than effective and was kind of a hard go, as these public officials, mostly men, generally weren't particularly interested in or responsive to the needs of the poorest, least enfranchised communities. So now in Women Strong International, we're working the other way. our programs are all designed expressly to fill the needs of the impoverished women and girls on the ground in these urban settings and to help them achieve the MDGs, or now Sustainable Development Goals, which would mean, of course, that by the time you're reaching these poorest of the urban poor, most of those goals have to be achieved. So as an example, this kind of community council or task force that I was talking about can be a tremendous community building tool, whether for public health emergencies such as Ebola, for natural disasters such as floods, where the evacuation routes, the emergency vehicles, the most vulnerable, the shelters on higher ground, or, for identifying, reaching out to, and engaging with depressed seniors or adolescents at risk or who's malnourished, et cetera. Such a committee can serve as a kind of a safety net or anchor for the community and gives people a sense of a circle or neighborhood that is containing, protective, and empowering. And there's no time when such structures, once they become embedded and relied upon, are more important than when a community's natural rhythms are disrupted, whether by an epidemic, a natural disaster, or even a man-made one, such as we're seeing in this country literally every day. Today, San Bernardino, yesterday, Chicago, the day before, Washington, D.C. If there's some structure that you can rely on, and believe me, it's going to be led by the women and the religious leaders often, where people can go to and have solace and feel not quite so alone, this is really the beginning and the survival, I think, of community building, because then, empowered, they can speak up and reach out to the leadership at every level. And with the support of organizations and governments and those who have the technical skills, American Academy of Pediatrics has been great. Lots of organizations have really stepped up to solve some of our chronic emergencies, which are simmering and just as important, really, in the long term and in the survival of the health system and of the next generation. Thank you.
So, Elegam, when you're thinking of investing in the health of women to ensure stronger communities, what do you think some of the goals would be to have the strongest impact are?
So I do think that, first of all, we have to look at it as a systems solution. So we even did this a little bit in Ebola, and we see that happening a lot, where we look at vertical solutions, just one issue, and we all focus around it, and then we send a lot of resources. So I feel like, first of all, we sort of need to change the paradigm of how we approach the investments in this to make changes for women's health. I think it is important to focus on safe motherhood. And when I say safe motherhood, I'm not talking about just the deliveries. I think family planning, birth spacing, all the, for adolescents, girls, nutrition, all the things that really will ensure that as the woman is being prepared to have a baby, has the baby, the facilities, the training of the health workers, the linkages to the community. But I think that you can think about all the things that you want to do. My big belief is you want to do it as an integrated solution in the whole health system. That's difficult because we are talking about bricks and mortar, we are talking about financing, then we are talking about training of health workers. Some of these things don't end up getting well funded. They don't hit. I know Avi is doing a great job with that in the focus on the systems approach, but a lot of people don't really focus on that. They focus on the vertical one solution, and I think that is short-sighted. We really do need to look at it as a comprehensive systems approach and really make the investment in all the different levels. The other piece that I want to mention is also education. So I'm the health person, but I also really do think that you want to invest in women's education, both the formal and informal education, because we actually have research that shows that when you educate girls and women, they make different choices for their health, for themselves, and also for their children. Breast spacing is a really good example of that. And so I think education in women is an important investment to the health of the woman long term too.
Thank you. Thank you. Well, as we look at moving on to the section where we'll ask questions, I'll open the floor up for us to consider where we might go from there.
Thank you. Now we'll go out to you, as Veronica mentioned. So if you wouldn't mind raising your arms and we can get started, we'd be happy to take them. I'd just like to mention, too, one thing that Elika mentioned about motherhood and the lines through it is that Roger Thoreau, who's a senior fellow with the council, and the McClungs have kindly supported, his new book is coming out in May around Mother's Day called 1,000 Days, where he looks at motherhood from conception to the end of year 2. It's a fascinating project, and I'm sure it has a lot of overlap with what you're talking about. So we have a quiet group yet today. All right. All right, Jeff Richardson from AbbVie here in the front row, please. Sorry, the mics are coming.
Oh, great. Yeah, thanks. Thank you. Excellent panel. Susan, you mentioned one of the ways in which to get things moving forward is to work with the faith community and also advancing women's rights and women's empowerment. But sometimes some of the faith communities are actually part of the problem in working with women's rights or gay rights or other kinds of issues. I'm just wondering, how do you navigate working with them, but also in some ways having them be part of the challenge?
It's a great question. You know, in the Millennium Villages Project, the sister project under Jeffrey Sachs at the Columbia University's Earth Institute, we had a gender team working in Millennium Villages on, FGM and other sort of traditional cultural practices and polygamy, and not realizing that the science coordinator, who's a PhD, actually is a polygamist, and so it's, this is your leadership, right? So it's a challenge. Or when we did an education needs assessment in Louga, Senegal, a beautiful sleepy town, it's kind of French post-colonial town, we thought, why the mothers say they want to keep their girls home, the 12-year-old girls, and the family's very sophisticated and worldly and can talk about public affairs in Europe and elsewhere, but why is this girl still at home? And she said, well, I need her to help around the house. I need her with the young ones. Turns out she wants her at home because the imam is abusing the girls at the school. So, this is very profound. And I guess I would say that at Women Strong, we're working to raise the voices of the women, and that somehow it's a huge societal challenge, but that in solidarity in groups, that at least they can speak up and begin to address these things and begin to shame the abusers. We're looking at whatever tools are available. Save the Children has some. We're looking at others for the Coalition for Adolescent Girls, for training educators in the treatment of adolescent girls. Because once people, and for how to out those who are taking advantage of adolescent girls. So it's starting from the bottom. There are some resources available. The conversation's beginning. I was in Washington at a USAID head for gender yesterday, was using the right talk about listening to the women and kind of raising the awareness of these issues and kind of seeing the last girl as a target. So I think there's progress, but thank you for the question, because it really is not simple.
Great. Next question. Adele Simmons here, please, in the front row.
First of all, thank you all very much.
The mic's there, Adele, because we're live streaming. Thanks.
Thank you all very, very much. Both of you are quite unique in that you're working with organizations that work in partnerships. And I'd be interested in, and this is unusual, it's difficult, and a lot of places don't want to do it. So I'd be interested in your comments about building partnerships, how that's worked, and what are the challenges?
So thank you. It is challenging, but I do think it is starting with a concept of mutual respect and really setting up also mutual goals together. And then also realizing that some partnerships will fail. So in my 9 years at Americas, there have been partners that we have had to not continue working with because we just could not meet somewhere close to the middle. But I think it is a commitment, first of all, as an organization to say we don't have all the solutions, that there's enough knowledge also on the ground for us as Americans, and for me personally, it's also realizing that there are people on the ground that know more than we do, who, like Susan said, know the solutions, but probably need help with a voice, need help with resources. And so that's what we bring to the table. What do we bring to the table? What are you bringing to the table? And how can you continue to work together? But sometimes we have had really challenging partnerships where we've had to walk away. They're not a lot, but it does happen. But I think one of the reasons I joined Americas was because they were committed to that spirit of partnership. And I think it comes from almost a place of humility, knowing that we don't have all the solutions and we can go further with working with
That's so
people
funny
like
because
this.
I just jotted down the word humility. You know, it takes a global village to save a planet, right? And we are really small and really underfunded, but in both the projects I've been a part of, and listening, understanding the need, and then bringing in capable partners. In Millennium Cities Initiative, that ranged from KPMG with private sector investment, a lot of top international law firms, DLA Piper, Cravath, Carter Ledger, to do regulatory reviews of the investment climate in these cities, Johnson & Johnson to help implement the American Academy of Pediatrics neonatal resuscitation program. There you have to work with their interests and their needs. KPMG did investment guides, the first investment guides, along with ours for cities at the city level in a number of our regional capitals. It takes care and it takes appreciation of what everybody has to bring to the table. We could never have done those things. We exploit every possible resource, the Columbia Business School, the Columbia Law School, the Columbia Health, School of Public Health, just because I've been there. And now that our independent nonprofit, I think the important conversations have to take place between, sorry for this, top and the bottom, but between the ground and the policymakers. They're not there, the people on the ground. I was at a bunch of side meetings, admittedly not the core UN meetings this fall, and they're talking to themselves. So corporate is not at the table at the UN Habitat meeting. How can that be? Who's going to pay to fix up cities? Where are they? And there was a woman there from Fed Up, the Federation of the Urban Poor. I love the acronym, from South Africa. It's a part of Slum Dwellers International. And she was on one of these panels, and she was just turning her head, and finally they got to her, and she said, I'm just wondering if in 20 years we're going to be sitting here hearing these same promises basically coming out of your same old mouths, and I'm still living with this situation on the ground with the running sewage. And I mean, she didn't say it that way, but that was the message. So we need to convene conversations on health, on education, on the intersection between these things, between people who care and who have resources and access to resources. So that's what we could do, was to be able to bridge some of the distance between the needs on the ground and those who know how to fix them. And those conversations have to really take off. And I think the advances in connectivity and in communication can help to make that possible in a way that wasn't even, when we began Millennium Cities Initiative 10 years ago.
Thanks. Next question. Yes, right here, please. Julie Steliano.
Hi, thanks so much for your discussion. And to your point about coordinated, integrated approaches, I think that I'm on the board of Women's Global Education Project, and we have programs in Senegal and Kenya. Just thinking about the major donors like USAID kind of sets up this competitive atmosphere where instead of collaborating, you're competing against some other not-for-profit to gain a huge grant so that you can do the work. And then there's no facility to combine all the skill sets of all of these NGOs on the ground to make an integrated solution to problems. And so I don't know if you have any comments about that, because it seems like at the top level of any given country, they should be controlling all these donors who are working in their countries to ensure that things are integrated with their own goals and missions. But oftentimes, they're working at counterpoint, so that creates problems.
I'll come to you.
So I think you're right. There are silos in the work that we do, which is really what we are talking about, and funding priorities drive those silos. I do think that for organizations as ourselves, it's also diversifying the funding helps to create more leverage for you. So we are lucky that we have folks like AV and some of our corporate donors that really support us in doing innovative things. So when we started Health Worker Safety, again, 2008, not a lot of people were focusing and investing in health system strengthening and focusing on protecting health workers. But having private donors, actually, I think to Susie's point, really leveraging private sector investment and really gives you a diversity of opportunities. Also, when we go into a country, as we work with the country, really listening to the leaders, the leadership, and tailoring your approaches and your priorities to what the ministries are saying is critical, because long term, at some point, we are going to walk away from that country, right? We should be walking away at some point if we've done our jobs well. So making sure that you are aligning your priorities to the national priorities, both from the donor perspective and also from the implementer perspective, is critical, because that is what then you build in the natural elements for sustainability. So in a field, sustainability now is a big buzzword. Everybody wants to know how sustainable is the program. The program is not going to be sustainable if it is different from the national priorities. It's just not going to be. So I think that we do need to make sure that both from the donor perspective and also from the implementers perspective, we are aligning our interventions and our work with national priorities.
I agree with that. One just has to be a little bit careful, because sometimes those in power may direct the aid to their favored region, for instance. So you'll see, oh, it's poorest up in the north. Well, it is poor up in the north, but are you going to deprive all these other areas of very targeted aid to what they need? So it's tricky, and it can be diverting, just as the crisis, as you were talking about, the vertical focus, kind of laser-like focus on HIV/AIDS 20 years ago. Okay, everyone said after that, oh my goodness, we forgot about the whole system because we were so focused on HIV/AIDS. So let's talk about system strengthening, with the WHO kind of buzzword for a while. And we're still talking about it. Ebola. So USAID and the whole US government was late. These 17 structures, care structures that we brought to Liberia, sat empty, sad to say, kind of after the need. So you can't predict, right? But how to be wise about, and to listen to the ministries, but to make sure that they're also consulting up and down.
Can I just add something to that? I think that you make an important point, because I think it is not just the national level priorities, it is the local priorities. So when you go into the local communities, they know what the problem is. So we in America, I think one of the things that we focus on, because our partnerships are really the health communities and the health centers in the rural, urban, local, hard to reach areas, you get to know what the problem is. So it may be lost, but the district health official knows what the problem is in his district. The head of the hospital in that community knows what the problem is. The nurse working in that community, it may not make the top 10 of the Minister of Health when you talk to the Minister of Health, but when you go into that local community and you talk to the chiefs there and you talk to the women there, you get what the real facts are. And so I think it is lining it up with not just national priorities, but the local leadership and the local actors, this civil society in the community, and what they are saying is critical. And I really do believe that you don't want to go in and create a parallel system to solve the problem, because that parallel system will never be sustainable.
Can I just add one thing about the competition that you mentioned for the, I have colleagues in the humanitarian area who call it, the feeding at the trough, the scramble. It's completely destructive, as you say. I mean, that's why we founded Women's Strong International, was to be completely open source and to convene like-minded organizations, the Women's Global Education Partnership, for instance, that can partner with us, that we can share resources. We don't need to reinvent the wheel. So much of the work has been done. We need to get to the field and to the villages and to the inner cities of all of these places, what's going to work. And it's very simple things. It's savings groups. It's girls' clubs. It's community health workers who know every last person. These are very simple and relatively low-cost things when it comes to a World Bank or ADB investment, but we need to get the word out where it matters. It's not glossy, and the president's not gonna be able to say, I brought in X, but it's actually what's gonna work.
Okay, we have just 5 minutes left. We have a couple of questions out there. I'll get both questions, and then we'll finish up with the blue and with the green, of course.
Hi, good morning. Thank you for everything. I'm from the University of Chicago, and you're an alum. It's been great to hear from both of your perspectives how critical the role is that kind of the corporate partners play in your ability to get the work done. And so I'd love to hear, Veronica, from your perspective, how you prioritize as they've kind of from your side of the equation, and how you pick partnerships and how you get that work done in defining, because you've been so generous in the global health context.
And in the green sweater too, please. Thank you.
Thank you. I think you both have done a great job touching on the physical, the political, the policy challenges that exist with this. I'm curious how you think of something like fear when it comes to raises women's and voices from the ground. How do you address sort of those emotional challenges in addition to the really easy to, pinpoint, how do you, something like Ebola is very fearful, especially when you're talking about, what we saw in the United States, but how do you address those emotional concerns as well?
Why don't we start off with Veronica and the corporate question? Thanks.
Sure, thank you for the question. So as we look at the work that we do at the AbbVie Foundation, our core focus is on health. So, it's quite a privilege to work with many of the NGOs with which we work. And partly it's highlighting, I think, something that came up earlier, which is leveraging the partnerships, leveraging the community and the global health stakeholders that are working tirelessly to work to solve many of these problems. And for us, it's really about looking at the priorities that we might have and seeing who the best partners are, who do we establish partnerships with, how do we build, sort of co-create programs that will have an impact, that will have, that we look for the elements of sustainability, we look for the elements of, how are they implementing programs, what are the methodologies that they're using to make a change, to affect change. So many of the things that we do is really looking at our priorities, looking at what we want to do in the health space, and looking for building the right partnerships, being at the right conferences to sort of meet the different stakeholders that are working in those communities. So much of our work is really much easier than the implementation piece of that, but what we're looking for in much of the work is who do we implement with, and that's really a part of building, a community of global health stakeholders and NGOs with which we want to partner with, and affecting that change as best we can.
Great, thanks. Alikam.
So the question on fear. Two quick examples since we are running out of time. I think using the people in the community, especially survivors, is a really important component of dealing with the fear factor. So when we worked in the Ebola treatment units, some of our staff members were Ebola survivors. As nurses in the treatment unit, they're the best ambassadors to convince a family to bring their loved one to the treatment unit. We also work in fistula. And so, again, the survivors are great ambassadors to talk about the process of healing. So I think leveraging survivors and people who can really tell their own voices, their own stories to be the voice. They can tell it better than I can. But I think you probably, with your working community, can talk a little bit about that too. But I think using survivors is an important part of the solution there.
It's a really important factor to take into consideration because people can't do what they can't imagine doing. And Ebola is like a monster. I mean, you just have no idea. So education, sense of community, facts, which is, of course, the salient piece of education. But the structures are when you get disparate communities that are even more disrupted by the crisis, then it's very difficult. Look, we're going to see today on the airwaves a lot of fear-mongering, a lot of irrational talk. and a lot of rumor, and it's an opportunity for politicians and people with an agenda to exploit a crisis. And how do you stay calm in the face of that? You know, you need facts. You need to rely on. I mean, we have the education to be able to do that. But so when the Ebola crisis came to the U.S., that was insane. And how to kind of bring people down to the ground with very practical things. What do you need to do to protect yourself? How do you keep this person safe? You know, and it's really very much, as Elikam said, about education and rationality and step-by-step kind of calm.
Ladies and gentlemen, please join me in thanking our panel for their marvelous remarks this morning.